Gastroesophageal reflux disease GERD and esophagitis. Gastric contents flow back into the esophagus in GERD due to incompetent lower esophageal sphincter LES. Esophagitis or inflammation of the esophageal mucosa may result. Pathophysiology and etiology. Gastroesophageal reflux associated with an incompetent LES, that is lower esophageal sphincter. Gastric contents reflux flow backward through the LES into the esophagus. Can be the result of impaired gastric emptying from gastroparesis or partial gastric outlet obstruction. The acidity of gastric contents and amount of time in contact with esophageal mucosa are related to the degree of mucosal damage. Inflammation and ulceration of the esophagus may result causing esophagitis. May be caused by motility disorders, achalasia, scleroderma, esophageal spasm. Clinical manifestations in GERD. The most common symptom is heartburn, pyrosis, often occurring 30 to 60 minutes after meals and with reclining positions. Complaints of spontaneous reflux, that is regurgitation of sour or bitter gastric contents into the mouth. Dysphagia is the less common symptom. Other symptoms include atypical chest pain, hoarseness, chronic cough, bronchospasm, that is asthma or wheezing, and odynophagia, that is sharp substernal pain on swallowing. Symptoms may suggest other diseases etiologies need further evaluation. Example, atypical chest pain to rule out possible cardiac causes, dysphagia, odynophagia or weight loss to rule out cancer or esophageal stricture. Signs and symptoms in esophagitis. First one, esophagitis is an acute or chronic inflammation of the esophagus. Severity of symptoms may be unrelated to the degree of esophageal tissue damage. Symptoms vary according to etiology of esophagitis. Symptoms include dysphagia, odynophagia, severe burning, chest pain. Causes of esophagitis other than GERD are infectious, Candida, herpes, HIV, cytomegalovirus. If it is chemical, alkali or acid. If it is medication induced, may include doxycycline, ascorbic acid, quinidine, potassium chloride, biphosphonates. Diagnostic evaluation. Endoscopy can visualize inflammation, lesions or erosions, and biopsy can confirm diagnosis. Esophageal manometry measures LES pressure and determines if esophageal peristalsis is adequate. This study should be used before patients undergo surgical treatment for reflux. Acid perfusion, that is Bernstein test. Onset of symptoms after ingestion of dilute hydrochloric acid and saline is considered positive. This test differentiates between cardiac and non-cardiac chest pain. Ambulatory 24-hour pH monitoring is frequently performed for diagnostics. It determines the amount of gastroesophageal acid reflux. Barium esophagoscopy. Use of barium with radiographic studies to diagnose mechanical and motility disorders. Management is divided into 5-phase approach. Phase 1, lifestyle changes. First one, head of bed raised 15 to 20 cm or 6 to 8 inches. Number 2, do not lie down for 3 hours after eating. Time frame for greatest reflux. Number 3, bland diet. Avoid garlic, onion, peppermint, fatty foods, chocolate, coffee, even decaffeinated coffee, citrus juices, colas and tomato products. Number 4, avoid overeating, causes LES relaxation. Number 5, no tight fitting clothes. Number 6, weight control. Number 7, smoking cessation. Number 8, reduce alcohol. Phase 2 treatment, first line drug therapy. Antacids reduce gastric acidity. Use on an as needed basis. Provide symptomatic relief but do not heal esophageal lesions. Number 2, histamine H2 receptor blockers such as ranitidine, that is Zantac, cimetidine, Tagamet, and famotidine, Pepsid. Decrease gastric acid secretions, provide symptomatic relief, may require lifelong therapy. Phase 3 treatment, second life drug therapy. Use of high dose H2 blocker, addition of prokinetic agent, that is metoclopramide, to promote gastric emptying, and addition of proton pump inhibitor such as omeprazole or lansoprazole to block gastric acid secretion. Phase 4 treatment, drug maintenance therapy, may be needed depending on the severity of disease and recurrence of symptoms after initial therapy. Drug therapy is stopped. Use of lowest effective drug dose of H2 receptor blockers or proton pump inhibitor. Phase 5 surgery may be indicated for patients who do not respond to other approaches or who do not adhere to strict lifestyle and pharmacologic management. Common procedure is Nissen fundoplication, NISSEN, Nissen, FUNDOPLICATION, Nissen fundoplication. In this upper portion of the stomach is wrapped around a distal esophagus and sutured, creating a tight LES. This procedure can be performed laparoscopically, combined with vagotomy, pyloroplasty if associated with gastroduodenal ulcer. Complications: number 1, esophageal stricture formation. Number 2, ulceration of the esophagus with or without fistula formation. Number 3, aspiration may be complicated by pneumonia. Number 4, development of Barrett's esophagus, that is pressure of columnar epithelium above the gastroesophageal junction associated with adenocarcinoma of the esophagus. Nursing intervention must include teach the patient about prescribed medications and side effects and inform patient regarding medications that may exacerbate symptoms. Then advise patient to sit or stand when walking any solid medication, pills or capsules. Emphasize to the patient and family what foods and activities to avoid, like fatty foods, garlic, onions, alcohol, coffee and chocolate. Staining, bending over, tight fitting clothes, smoking should be avoided. Encourage the patient to sleep with the head of the bed elevated, not pillow elevation, together from head to the body. Encourage the weight reduction program if the patient is overweight. Thank you.